اهلا بيكم. الفيديو دوت اول فيديو بعمله علشان التحضير للنفلي اللي بفكر فيه في التحضير للنفلي او في البي اس اي. هو باختصار ايه المعلومات اللي انا خدت النفلي دوت من 10 سنين. ما كانش عندنا بي اس اي. ايه المعلومات اللي تملي موجودة في دماغي؟ المعلومات اللي تملي موجودة في دماغي دي معلومات بسيطة جدا. اتكلمت مع اكتر من واحد وحاولت اني اشرح في اعتقادي ايه هي الفكرة ديت، انه الفكرة اللي بتخليك تقدر تنجح في الامتحان وتخليك تقدر تمارس الطب بعد كده. الفكرة هي انه المعلومات اللي الواحد بيعرفها، اللي اي بني ادم يقدر يعرفها، معلومات محدودة جدا، كمية بسيطة جدا من المعلومات. مفيش بني ادم يقدر يحط كل الكتب ديت في دماغه. والدليل على كده ان الكتب اللي بتلاقيها مراجع، يعني ما بيبقاش كاتبها شخص واحد، بكتبها مجموعة من الناس. فالفكرة انه لما بتيجي تخش الامتحان اللي انت محتاجه هو نفس اللي كنت محتاجه في مصر. يعني كنت محتاجه في مصر انه تعمل الامتحان. لما تيجي تخش امتحان الكليه محتاج ان انت تبقى عارف يعني كلمتين ورقتين كده اللي هما كانوا ورق الدرس. هو ده اللي فيه الخلاصه. انما ان انت تقعد تذاكر كميه كبيره جدا من المعلومات ده مش هيخليك تنجح، مش هيخليك تجيب تقدير. فاللي هي نفس الفكره موجوده في امريكا وموجوده في كل حته. الفيديو يعني كنت متردد اعمله بالعربي ولا اعمله بالانجليزي، لكن في الغالب هعمله هكمله بالانجليزي ونكمل من هنا. حاجة مهمة عايز اقولها، انه الفيديو اساسا كان عن السمول انيمال اندوكرينولوجي، لكنه في الغالب هيتفرع على حاجات كتيرة جدا. كنت بكتب نقط وبعدين لقيت اني زي ما بيقولوا الشيء بالشيء يذكر، الموضوع اتفرع. حاجة أهم من كده، لو الفيديو عجبك أو لو استفدت منه أو لو عايز نعمل فيديوهات تاني، يا ريت تعمل أي نوع من المشاركة زي لايك أو كومنت أو أيا كان، بحيث إني أعرف إنه في حد بيستفيد من القصة دي. So, well, let's start. So, what we're going to talk about today is mainly going to be small animal endocrinology. We're going to start with one of the main presentations of small animal endocrinology or small animal endocrine disease, and we're going to go from there on many route trails to try to gather as much information and link it together. I guess that's how it's tied up in my mind. That's how I used to remember things when I was preparing for the NABLE. So, what is the main presentation for endocrine disease? Now, there could be so many different presentations, but the most common one, unless you're presenting with an emergency, the most common one is going to be PUPD. What does PUPD means? PUPD mean polyuria and polydipsia. Polyuria is where the animal is going to urinate a lot, and polydipsia is where the animal is going to drink a lot. So the polydipsia part of things is usually a compensatory mechanism for the polyuria. So the disease is that the animal is urinating a lot, okay? And to compensate that, the animal drinks a lot. There are a couple of exceptions where the disease is that the animal is drinking a lot and then consequently he urinates a lot. But that's not the norm at all. That's the exception, and we're going to get to that. Mainly that's psychogenic drinkers. The psychogenic drinker is an animal who is a psychogenic drinker. He's just like a human who's an alcoholic. He drinks a lot just because he likes to drink, or because he's got a psychological disorder that makes him drink a lot. That's what psychogenic drinking is. And that's a diagnosis of exclusion when we find out that the animal has no disease to cause him to urinate more than normal, so we judge him to be a psychogenic drinker. He's just drinking a lot, and the solution is restricting water. Now, that's a very dangerous diagnosis, because if we are actually restricting water from an animal who is urinating a lot, who has a disease that makes him urinate a lot, then that animal, if we restrict his water access, he's gonna become dehydrated, and that could end up in a crisis and could cause renal damage and so on and so forth. So that's a problem. So we need to make sure of the diagnosis. So let's start with some definitions. What does polydipsia mean? We're going to start with that. What does it mean when the animal is drinking a lot? Well, a normal animal will drink 60 ml per kilogram per day. That number is important because that's also the animal's daily water requirement. So if they ask you, what's the daily maintenance for an animal, that's 60 ml per kilogram per hour. Per kilogram per day. So if I have an animal that's like 22 pounds, he's going to be 10 kilograms. So he is going to need 60 ml per kilogram. He's going to need 600 mLs of water to drink. And if he's not drinking, I'm not giving him fluids, IV, that's what I'm aiming for. His maintenance is going to be 600 ml per day. So you divide it by 24, you get the hourly rate. Now, one thing to know is that this is not very accurate. A more accurate formula is going to be the animal's weight to the power of 0.75. You need the scientific calculator to do that, times 70. Okay, so that will also give you his maintenance fluids, and it will also give you his maintenance caloric requirements. So that's an equation that's important to know. Animals' weight in kilograms up to the power of 0.75 times 70, that will give you the accurate number. However, we can, we can replace that with the rough estimate of 60 ml. So that would be 50 to 70 ml per kilogram per day. Now, we would say that the animal is drinking a lot if he's consuming 80 to 100 ml per kilogram per day. Okay? And again, forget about that, that's not important. Okay, that's polydipsia, that's when he's drinking a lot. So let's go to polyuria. Now, polyuria is way more important. What is polyuria? Polyuria is when the animal does not have concentrated urine. So we can measure it. It would be 50 ml per kilogram per day, but we usually cannot quantify the urine. So what we want to know is this urine concentrated enough or not? If it's not concentrated, then that means that the animal is urinating a lot. So what's the magic number for cats and for dogs? For cats, it's 1.030 specific gravity. So specific gravity is a measure of the urine concentration. And again, I don't know. I guess we have lots of different levels, graduation dates who are listening to the video or who might be listening to it. So I'm going to explain things that might be old news for some people or old information. We already know that. So let's see. Specific gravity is how much heavier is the urine compared to water. So water would have a specific gravity of 1. Okay? If I say that the urine is specific gravity is 1.030, that means that the urine is 1.030 times heavier than water per volume. Okay, so So if I have 1 liter of urine and 1 liter of water, the 1 liter of water always weighs 1 kilogram, but the 1 liter of the urine that's got a specific gravity of 1.030 will weigh 1.030 kilograms. Okay, so that's what specific gravity is. So it's a measure of how concentrated the urine is. In the cat, it's 1.035. Okay, so 1.035 in cats is the cutoff. Anything below 1.035 is dilute urine. Anything that's more than 1.035 is well concentrated. Kidney that's lost its concentrating ability will not be able to concentrate the urine above 1.035. So now we've defined what a dilute urine is. The disease, the polyuria, is defined as 1.03, as less than 1.030 in dogs and less than 1.035 in cats. So if you get a client, happens all the time, client says, well, this dog's urinating all the time. Sure, fine. Get me a first urine in the morning. Why? Because when the animal just woke up, he hasn't had the chance to drink, and when he's sleeping, he's not usually drinking. So the first urine in the morning is the best measure of urine specific gravity. So it gets me the urine sample, and then you use a refractometer. A refractometer is a certain device to measure the urine specific gravity, and we got 1.045. Well, if the urine specific gravity is 1.045, this animal is not urinating more than normal. Now, the client might think that he's urinating more than normal, but he's not. So, I mean, one of the arts of this profession is to find a way to tell the client, well, no, you're not right, because the client is 100% sure they know their animal very, very, very well, and that they know that the animal is drinking more than usual or urinating more than usual. But if he's got 1.045 specific gravity, anything that's above 1.030 for the dog, he's not urinating more than normal. So let's go do some physiology. We'll get back. Okay. So how is urine formed? Well, urine is formed basically by sieving the blood, filtrating the blood, and then taking the filtrate and removing some stuff from it, adding some stuff from it, and pouring it out through the urinary bladder. That's how the thing works. So the kidney functional unit is made of something called the nephron. Nephron is made of Bowman's capsule. Bowman's capsule is this thing that looks like a cup, and then there is a capillary of blood vessels, and the capillary of the blood vessels acts like a sieve. Sieve, I'm going to say that in Arabic. I mean, it was a new word to me. Like when I first heard it, it was in Bowman's capsule. So the sieve is musfayan. Okay, so the sieve filtrates the blood. So what everything passes through the sieve except two things. They're not supposed to pass. Red blood cells, they're too big to pass, and in a normal nephron, under normal blood pressure, protein, especially albumin, so albumin is the smallest protein, globulins are bigger, but you're not supposed to have any proteins pass through the kidneys, through the sieve. If you have protein passing through the sieve, that's kind of a kidney disease, and that's damaging to the kidneys. That's how high blood pressure damages the kidneys. Because if you have the sieve is like this, and we have very high blood pressure pushing things through it, Then these big things that shouldn't pass, like the albumin, will pass. And when they pass, they make the pores bigger and they ruin the sieve. It's not a sieve anymore. Guys, if you're pushing big particles through it, then you make the holes bigger, you damage it. Okay? So that's how hypertension damages kidneys. And by the way, and again, every time I say by the way, I don't know, I mean, maybe you can write it down, because that's how I remember things as I go along. That's what helps me guess the answer to questions that I don't know the answers to when I'm taking a test. So hypertension and kidney have this relationship. Hypertension will cause kidney disease by the mechanisms I told you about, and kidney disease will cause hypertension. Okay, so the one causes the other. Okay? So whenever you get an animal that's got kidney disease, one of the main things that you need to do is you need to check his blood pressure, especially cats. So you get a cat with kidney disease, you need to check the blood pressure. Okay? And if the cat's got elevated blood pressure, what do you do? Because the reason I'm mentioning that is, I'm sorry, maybe the video becomes so long, but the reason I'm mentioning that is because when I was listening to videos preparing for the test, and they would say, well, yeah, you find that if the cat has blood pressure, and I think, well, okay, so how do I treat it? If they don't tell me, then I have to go look for it. So you treat it with something called amlodipine, calcium channel blocker. That's it. So you get the cat that's got kidney disease, you measure her blood pressure. What's the magic number? 180. If the systolic, we are not measuring everything. We're just measuring the systolic blood pressure. We don't really care about the diastolic one, like humans. We're measuring the systolic blood pressure. The best way to measure it is the Doppler. So the Doppler is basically an analog thing. So it's not a digital device where you hook it to the animal and that will give you the reading. No, the Doppler is a device that you put on the artery, and then you can hear the artery pulsating like that's right here. So you inflate the cuff till the sound disappears, the goes away, because you're holding off the artery, there's no pulse. And then you start gradually loosening the pressure by the gauge, and then you see at what blood pressure or at what pressure on the gauge you start hearing the whooshing and the thing. Then that's your systolic blood pressure. So if we have a cat that's got kidney disease, you will measure the blood pressure, and if you find the blood pressure above 180, you put the cat on amlodipine and measure the blood pressure again in maybe a couple of weeks. And that might be a test question. The most accurate way is the Doppler. Okay? You measure the blood pressure using the Doppler. If it's above 180, put the cat on amlodipine. So now back to the kidney. So we said that the kidney is made of this capillary network, and you will sieve the blood through that into Bowman's capsule. Then after the fluid is filtrated, then the filtrate will have some stuff added to it and some stuff removed from it. So things like glucose, for example. Glucose is a part of the filtrate because the blood has sugar. So when we do the filtration process, this filtrate does have the sugar in it. The kidney function is to pull the sugar out of the filtrate and pour stuff in, usually sodium, but in BUN. But that's one thing to know. So there is something called Fanconi syndrome. Okay, so what is Fanconi syndrome? Fanconi syndrome is where the kidney is losing stuff that it shouldn't lose, and then that's when you find glucose in the urine, but you don't find glucose in the blood. If you find glucose in the blood, glucose in the urine, that's good. That's diabetes. That's really important. If you find the blood, the blood sugar elevated in the blood, hyperglycemia, but you don't have glucosuria, then that's really questionable if you can diagnose diabetes mellitus. You really cannot diagnose diabetes mellitus without sugar in the urine, without glucosuria. So Fanconi syndrome is where you have these kidneys that lose their ability to reabsorb the sugar of the filtrate. Another reason why you would have glucosuria without hyperglycemia, where you have sugar in the urine without having the blood sugar elevated, that's pyelonephritis sometimes. So you get a kidney infection, the kidney is diseased, cannot function, and it will do that. Not in chronic kidney disease, very unusual. I mean, I haven't heard of it, chronic kidney disease. It's a very rare thing, but sometimes these rare incidences where when you see it, it's pyelonephritis. So the kidney will, again, we pour the filtrate in, and then the kidney will pull lots of this water out and will add stuff to it. So what controls whether the kidney is gonna pull water and how much water would it pull? Well, what controls that is hormones. And that's why I was saying the main presentation for hormonal disease or endocrine disease is PUPD. The animal drinks a lot and urinates a lot. Animal drinks a lot and urinates a lot can be Cushing's disease, which is too much cortisol, can be Addison's disease, which is too low of cortisol and aldosterone, could be diabetes mellitus. There's, sometimes it's low insulin, but also sometimes it's lack of insulin sensitivity, and other things like pyometra that's actually acting in a hormonal way. Okay, so what's the main hormone that affects the kidney's reabsorption of water from the filtrate that was filtered by the Stevens-Bowman's capsule? That's ADH, antidiuretic hormone. And kind of lots of these things that cause PUPD, or you can say probably all of them, have to do with the interaction with ADH. Okay, so antidiuretic hormone. A question that sometimes comes in the exam is what's the site of actions? The collecting tubules. So antidiuretic hormone acts on the collecting tubules. So what other hormone is really important? Well, another hormone that's really important that affects the water absorption is the aldosterone. So what is aldosterone? So aldosterone is a hormone that causes, and again, that's one of the key phrases that I've always remembered since my days in school, and that's what always helps me think through, like I use that as the given, and then I build up one step after another till I remember the parts that I forgot about diseases. So aldosterone causes water and sodium retention. It causes water and sodium retention. It causes the kidney to keep the sodium and keep the water. Okay. So aldosterone is secreted by the adrenal gland. The adrenal gland secretes two types of hormones. One is the cortisol, and the other one is the aldosterone. So aldosterone causes water and sodium retention. Okay. Well, what does that mean? If I have a lack of aldosterone, which is Addison's disease, then we're going to have a reduction in water and sodium retention, which is going to cause water and sodium to be poured in the urine. So the animal will get dehydrated and will get low sodium. Okay? And that's that's how we diagnose Addison's disease or hypoadrenocorticism on the lab work. You find a changed sodium-potassium ratio. You find blood work where the sodium is low and the potassium is higher than normal. That is the function of the aldosterone. Now, one thing again, that's a rabbit trail. That's how we remember things next to each other. There is something called potassium sparing diuretic. So potassium sparing diuretics as opposed to like loop diuretics, which are the normal ones. So loop diuretics, the normal ones like furosemide. The most common one is furosemide. Well, what does it do? It goes to the loop of Henle, and it causes water loss and everything loss. It causes loss of potassium, loss of sodium, and loss of calcium. Everything gets lost in the urine alongside the water. But spironolactone, you can notice the resemblance in the name. Spironolactone is similar to aldosterone. That's because there's molecular resemblance. So it just blocks the aldosterone. So if I block the aldosterone, what do I get? I get potassium sparing. We're going to lose water and we're going to lose sodium because the aldosterone causes the retention, which is the opposite of the loss. It causes the body to hold on to the water and the sodium. But if I have a molecule that looks like aldosterone, but it's not aldosterone, that blocks the receptors, then I'm going to have a lack of action of the aldosterone. So I'm going to have more water loss through the kidney and more sodium loss through the kidney. And I'm going to have more potassium retention. So the aldosterone will cause retention of the sodium and loss of the potassium. Okay. So when I have the spironolactone will cause the opposite. Will cause the water loss and will spare the potassium. Will prevent the loss of potassium. Loses water and sodium, prevents the loss of the potassium, which is the opposite of what the aldosterone does. That's why we call it the potassium sparing diuretic. So again, the reason I'm saying that is because that's how I tie information together. Spironolactone, the name of it, the ending of tone, reminds me of the aldosterone. Okay, so, and it does the opposite effect. It's a competitive inhibitor of aldosterone. So more on Addison's disease. What is the typical presentation of Addison's disease? That's a middle-aged female poodle. If you go to the Navli and they say, well, 5-year-old female spayed poodle presents for PUPD. I mean, before you finish reading, that's going to be Addison's disease, okay? So that's a typical presentation. So, well, what does this present as? Well, it could present as Lack of energy, PUPD, and we're drinking a lot in uranium, or it could present with another category, another group of signs. What is that? Lack of appetite, animals having diarrhea on and off. Why is that? That's because of the other hormone secreted by the adrenal, the cortisol. So when I have a disease of the adrenal, if I have low adrenal activity, I'm having a problem with the aldosterone and with the corticosteroids. Aldosterone affects water sodium balance, affects electrolytes, and affects the water balance, and will cause the animal to be dehydrated because we're not having water and sodium retention, so we're having water and sodium loss, and then you get dehydration, you get hypotension. That's something that's very easy to remember. If your grandpa or your dad, or maybe you yourself, if you're as old as I am, have heart disease or have hypertension, so they tell them, well, don't consume lots of salt. So salt raises the blood pressure, so which is sodium. So sodium raises the blood pressure. If we lose sodium, then we're going to have hypotension, low blood pressure, on top of us being dehydrated, having hypovolemia, having a low circulating volume because we're losing the water through the urine. So that is the effect of lower than normal aldosterone. But the corticosteroids, which are like cortisol, that has a different function. That is important for the health of the gastrointestinal tract. So that usually presents with the gastrointestinal signs. The animal might be vomiting, or having, more commonly, on and off diarrhea, having variable appetite, sometimes eats, sometimes doesn't. That's cortisol effect. So Addison can present with two of them: the PUPD, drinking a lot and urinate a lot, and the gastrointestinal signs. So what else? Well, there is another type of Addison, or it's called atypical Addison. Why is it atypical? It's atypical because it's just cortisol deficiency. So these animals present with lack of appetite, diarrhea on and off. So what makes you suspect this animal has atypical Addison? First, it's atypical Addison, so you're going to look at your sodium-potassium ratio is going to be normal. And in many cases, you're going to find the urine-specific gravity normal. So what makes me think that this is Addison? Well, stress leukogram. So let's pause here and go to the leukogram. What is the leukogram? The leukogram is a distribution of and the number of the white blood cells. So typically, if I am sick, my stress hormone, the cortisol, will go up. When the stress hormone goes up, it causes a certain characteristic distribution of the white blood cells. What I remember that as, because it's very important to remember, is that the body is getting ready for war. It's getting ready to eat the invading organisms. So what goes up? The neutrophils and the monocytes. The monocytes are what will turn into macrophages. So they're circulating in the blood. They're macrophages. They leave they're monocytes, and then they leave the blood and go into the tissue. Then we call them macrophages. They're the same cells. And then the neutrophils have another older name or less common name. It's called microphages, because they're phages as well. They'll do phagocytosis. They'll eat the organism. So the body is getting ready to for war because it's under stress. So it deploys the neutrophils and to a lesser extent the monocytes, and there are other cells that we will have less of. These are the lymphocytes and the eosinophils. The eosinophils and the lymphocytes will be less. Okay, so I look at the lab work, and I have an animal that's presenting for on and off diarrhea, and he's having lack of appetite. So in other words, the animal's like kind of sick, عيان شوية, okay? Which means that he's under stress. Cortisol levels should go up, and then I should find neutrophils and monocytes up, and it should find the lymphocytes and xenophils down. Well, if I have a stressed animal presenting because he's sick, who does not have the stress leukogram, or even worse, have a reversed stress leukogram, has the opposite of that. So instead of having the neutrophils and monocytes up, has the neutrophils and monocytes down, and has lymphocytosis, has higher than normal or upper normal count of lymphocytes and upper count normal of eosinophils, that's very likely to be a typical Addison. How do you rule it out? You call the lab, tell them, well, can we measure the cortisol level? Of course, call the client first, make sure he's going to pay for the test. Okay? And hopefully he agrees to that. You call the lab and you tell them, well, let's measure the cortisol level. If you find the cortisol level above 2, that rules out Addison. If you find cortisol level below 2, that makes Addison really suspicious. Well, every person now, everybody now is going by the book, and we're running all the tests under the sun. So at this point, lots of people will run a confirmatory test. What is a confirmatory test for Addison? It's an ACTH stim test. ACTH is an acronym for adrenocorticotropic hormone. So it's a hormone that will cause the adrenal cortex to undergo trophism, to become bigger, more activated. So the ACTH, we will measure the cortisol levels. So we get the baseline, inject the animal with ACTH, synthetic form, manufactured form of ACTH hormone, and then after 1 hour we pull another sample and see if the cortisol level has gone up or not. If it hasn't gone up, then that means that the animal has failed to respond to the stimulation of the ACTH, which means that its adrenal gland is diseased because it failed to respond to the stimulating hormone. Right? So that's the confirmation. Well, another way of, how do we treat it? We treat it with a physiologic dose of prednisone. So what's the physiologic dose of prednisone? 0.1 milligram per kilogram to 0.25 milligram per kilogram twice a day. You could, and again, that's how I remember it. In the dog, the dose is 0.25 to 0.5 milligram per kilogram twice a day. That's for anti-inflammatory dose, and for immunosuppressive dose, it's 0.5 to 1 milligram per kilogram twice a day. So the physiologic dose is even half of the anti-inflammatory dose. The anti-inflammatory is like the low dose. So